Good afternoon, everyone. As an elder, I'm very honored to be here. When people make fun of me and go, "Oh, you're getting old, Dr. Avalos," I always say, only the lucky ones get to get old. And I hope that every one of you young people lives to over 100, like me, like about 120. And the other thing that I can tell you with confidence is that life gets better. And sometimes we don't think that, but there's a lot of reasons to want to get older, and certainly if we have HIV, we want to get as old as possible. So I'm going to talk to you about dual therapy. Is it something for adolescents? Absolutely. And I hope by the end of this you can become advocates in your own country to make sure that everyone gets the best optimized treatment, which includes dual therapy. So these are my disclosures. I'm going to talk a little bit about setting the stage for dual therapy, some clinical and cohort studies, the WHO finally latest recommendation on dual therapies in development, and lessons learned from Botswana. So what's the rationale about using dual therapy? First off, it reduces the drug load. So less drugs, less toxicities. And this is particularly important in the age of tenofovir because we are seeing more and more drug-related toxicities with long-term use of tenofovir. Also, same thing, fewer complications, more favorable safety profiles than the older legacy regimens. I think there's still people on the continent that are still using the efavirenz, still using the lopinavirs. I mean, medications that really shouldn't be used anymore. We have so much better available now. Cost for dual therapy is cheaper than triple therapy. When we did our original cost evaluations, cost effectiveness studies, in Botswana, we said as soon as we had a full shift to dual therapy, we would be saving $6 million a year. So it makes sense on every level. So here's some dual therapy research. Actually, when I started to do this slide, I thought, I'll put some of the more important studies. But there were so many that I thought, okay, there's just too many studies. So I put really the really important clinical trials that have taken place, Gemini 1 and 2, really from as far back as 2018, we've known that dual therapy is superior, can be, well, certainly not inferior, but for all of the reasons just mentioned, superior to triple therapies, some of the triple therapies. There was Tango in 2020 and 2022, and I can tell you there's just as many cohort studies, real-world cohort studies, that show the exact same thing, that dual therapy is incredibly safe and effective and long-lived. So this is one study I wanted to bring to your attention because what we're seeing in Botswana, and I know I've spoken to many people across the continent, we're seeing too many people that are on ART that are developing kidney disease. And this is, again, long-term ART use, particularly to renal toxic tenofovir. And this study showed that antiretroviral therapy, dual therapy, 3-TC-DTG, was just as effective in end-stage renal disease, and also you didn't need to dose reduce. So you could still take that one pill once a day. And this is really important for anybody that is taking care of patients with renal disease because sometimes you have to take a Bacavir, 3-TC and DTG, many pills once a day if you don't have a co-formulated medication. So this is really great news. So again, finally in July, WHO, after really 8 years of good clinical evidence, has recommended the use of dual therapy. And I'm happy to say that Dr. Haulate from Botswana, who sits on the WHO board, was able to present some of Botswana's data that was important in making the decision for this recommendation. And essentially, WHO said, if you have achieved full viral suppression on oral heart and you're stable, you're eligible. If you do not have active hepatitis B, co-infection, and if you've been facing adherence challenges on oral ART, you would be eligible to possibly be switched to dual therapies. This recommendation is really about decreasing toxicities that are all ART is associated with increasing toxicities the longer you use it. I'm always saying it's not aspirin, it's chemotherapy, and we want to use the safest, most effective medication that's available in order to keep especially young people who have HIV well and alive and without HIV resistance mutations. So again, when new therapies like long-acting therapies become available, you can go right onto them without any problem. However, there are certain circumstances where caution should be taken, particularly patients that have failed already, people that have serious comorbidities, polypharmacy, have already developed HIV drug mutations, and even people that have had previous drug-drug interactions, negative interactions. So it may not be available or be safe for everybody, but the vast majority of patients, and certainly adolescents, it's safe. So promising future, I have to say that I did use AI for some of these slides, and hopefully it is going to be a promising future with the use of AI. So we're going to talk about first what's coming from ViiV Healthcare, and not only, we have to take a minute and give ViiV Healthcare their flowers, because not only did they pay for this conference, but they've really been at the cutting edge of innovation. Dolutegravir has changed the landscape, dual therapy, cabotegravir, and now we have 4 more in the pipeline and probably more, and each one of these has increased potency. Cabotegravir rilpivirine, which is a long-term injectable that was always given for every 2 months, now can be given, or it's under development to be given every 4 to 6 months. And I want to say something about cabotegravir rilpivirine, because in Botswana we had already approved the use of this on our guidelines committee in 2023. But Johnson & Johnson, unfortunately, decided not to make rilpivirine available for treatment. Boo, 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 boo. But we can't blame ViiV for that. But hopefully, now with these new formulations, that will change. And again, this is where advocacy is extremely important. So we have something called VH184. It is active against previously resistant mutations to INSTIs, really important. We have VH499, again, positive results from phase 2 trials. Oh, a fly just came. VH310, same thing, many under development. In fact, I can't remember a time when there were so many promising ART under development. So this is really great for all of you. From Merck, we also have once daily orals with doravirine and islatravir. We introduced doravirine as a second-line medication in 2023, and we've had very, very positive outcomes. We have patients that have had what we would call extreme drug resistance that have been put on doravirine and have suppressed. So again, really good news. Islatravir is a beautiful drug. They've taken care of some of the issues that they found originally with decrease in CD4 counts. There's also going to be a once daily oral treatment of islatravir and lenacapavir, and once weekly with islatravir, and we'll call it ULO. But this is exciting because more and more we'll be able to actually tailor your treatment, our treatment, to what is actually best for everyone that is coming into the clinics. Never has there been a time like this before. So let's talk a little bit about what's happened in Botswana. You may know, or you may not know, we have a pretty big epidemic here of 15.7% prevalence for adults, about 359,000 patients that have HIV. I put the numbers for new infections and deaths in red because even though we've done incredibly well in our treatment program, there's way too many infections that are taking place, and there's way too many people that are now dying of HIV. And that's a lot of different issues, not just ART, but also service delivery. You may have heard that Botswana declared a public health emergency last month. The good news on the other side of that is there's so many people that are working so hard to put things right again and to make sure that we maintain the successes that we have so far in our treatment program. Essentially, with the 95, 95, 95, we've reached those targets really years ago. And I tell everyone, 95, 95, 95 is a slogan. It doesn't really tell you what's happening on the ground, and it certainly doesn't tell you what's happening with adolescents on the ground. So this is something to remember. It's a wonderful achievement, but we still have a lot of work to do in Botswana, really, and across the continent. So if we look at new infections, we can see that in our urban centers, we have way too many young people that are getting HIV. And actually, that goes really all the way across. Not only that, but young women, 15 to 24, make up 9% of the population, but 27% of all HIV new infections. And women in general, 25 to 49, make up 19% of the population, but 32% of all new infections. So this is still a women's epidemic. I mean, obviously men too, but it's something that really we have to take into account and figure out, how do we reach young women? How do we reach women across the board? How do we make sure that everybody understands the importance of testing, the importance of treatment, and which regimens to take? So this is a poster that was presented. This is work from the Botswana Baylor Children's Center of Clinical Excellence. I can never just say Botswana Baylor. And I'm bringing this up because one of the things about dual therapy is that you want your program to be strong, right? And Botswana Baylor has proven to have one of the strongest adolescent centers on the continent. And what this, and I included it even though it's triple therapy, so it was looking at 5-year outcomes of adolescents on triple therapy containing DTG. And what you can see here is that even at 5 years, over 88% of the adolescents were suppressed. This is an achievement, right? And we had challenges along the way in Botswana with viral load coverage, but still, all of those patients, the majority of those adolescents have done extremely well. And even the ones that had viremias, low-grade viremias, or fully failed, so had 2 out-of-range viral loads greater than 400, were able to actually resuppress after counseling and intervention. So this is also good news, right? It's very difficult to fail DTG. It's because you've had viremias for a long time, you haven't had viral loads possibly, and nobody has changed your medication quickly. So the other thing we found with this study was that older adolescents tend to fail more than younger ones. So again, how do we now reprogram to make sure that, sometimes you hear the same thing in clinic again and again and again. And how do we reprogram ourselves so that we're relevant when an older adolescent comes in and we actually can relate to them? All the things you guys have been saying so far. The other thing that's important, because people will say, well, will dual therapy work? Will people take it? Well, the truth of the matter is they've been taking triple therapy incredibly successfully. It's 1 pill once a day, just like triple therapy. So why would there be a difference? Sometimes common sense should rule. So despite our operational challenges, some of the things that Botswana, I'm going the wrong way here. No, I've really gone the wrong way. Sorry. Okay. So one of the things that Botswana has been able to do is to continuously optimize our treatment. And you can see this is just a graph from a table from 2001 up until 2023 when we introduced dual therapy. And we've done it in a conservative way. We said that patients need to be suppressed for at least 2 years on a triple therapy, and then we can switch them over. And then in 2025, just a month ago, we decided that we would expand dual therapy to adolescents, and we also have said that if a woman becomes pregnant on dual therapy, we keep her on dual therapy, and we're not going to be switching her off. So I think we're going to be seeing, again, more and more success stories with dual therapy in Botswana. Another thing that we do, and I'm a big advocate for, is optimal viral load testing. Everyone really should get a viral load test every 6 months, because what happens is patients come in, they get there. If you only get a viral load every year, you come in, and sometimes you don't find out you have a viremia for 2 years. And that's what causes resistance mutations. Almost every naive patient who begins DTG cannot fail it as long as they're taking the medication. So when you hear about really high HIV drug resistance rates in Malawi and sometimes in Brazil, you have to say, operationally, what's happening in those countries that people are allowed to be viremic for as long as it takes to develop resistance mutations, right? So if you have, which we have for children and adolescents, physicians can order viral loads every 3 months if they're concerned about that patient, and for adults every 6 months. You catch people early and you keep them safe, because most people that stop taking medications stop taking for a reason. And believe me, I've heard every single reason you can imagine. And it's important to be able to say, to say to your healthcare provider, what are your challenges? Why did you stop taking something that you knew was really important? So we have to be able to make sure that our programs are strong enough to provide adequate psychosocial support and adequate viral load monitoring. In 2023, we also said, let's just see if we introduce 30 days of DOT, what happens? And I can tell you, once a patient is found to be viremic, we introduced DOT, and it has been extremely successful. Everyone thought, oh, no one's going to want it. It's not like 6 months where you do, if you have TB, you get 6 months of DOT, just for 30 days. And what we have found is that patients respond positively to it. So it was an innovation that has really made a difference. So in September, we decided we had to prioritize in the switching to dual therapy. And so we decided we would start with patients who already had renal insufficiency and had any kind of chronic kidney disease, because we wanted to get them off that tenofovir as soon as possible. Then we followed that by patients who were a bit older, 50 years or more, or anyone who had been on treatment for more than 10 years. So that's where the younger population came in, and then everyone after that. And unfortunately, we have had some challenges, again, with supply chain, but we're back on track now, and we figure that within the next 2 years, 2 to 3 years, we'll be able to switch people that are on triple therapy onto dual therapy, 3-TC-DTG. And in our guidelines, you'll also see that our second line is doravirine and darunavir. And again, this has proven to be extremely successful in resuppressing patients who fail first line. So just to give you a little bit of preliminary data from Princess Marina Hospital, looking at 332 patients that were switched, 72% of those patients had at least one viral load over 2 years, and 99% of them suppressed. And of the 2 patients who were found to have viremias, one suppressed with resistance testing and the other suppressed when they were put back on triple therapy. So our experience has been incredibly positive. So what can we attribute Botswana's success to? And I think sometimes we don't do such a good job of tooting our own horn because everyone really are more implementers than researchers. But we have been very, very lucky in Botswana to have been able to optimize treatment, to have a biannual viral load monitoring, 3 months for children. We've had resistance testing available from the beginning. We have an outstanding EMTCT program. We are the first country in the world to have gotten the gold tier status for PMTCT. It's something we're really proud of. We've had, yeah, really. The only country in the world. We have a strong political will and financial support, and that political will has been there really since the beginning. And as somebody mentioned, you know, we have a new government, and that government is just as committed, if not more so, to making sure that our program stays strong, and that has been huge. So we've had beautiful, wonderful, and generous development and research partners, of which we are very grateful. So in conclusion, there's absolutely no question that dual therapy is not inferior to triple therapy. However, you do have to make sure in your countries that it's strong enough that you can track patients well, that you have viral load monitoring, and that you can make sure that you have psychosocial interventions as soon as possible when someone's found to be viremic. And I don't think even in Botswana we have the kind of psychosocial support really that we need. So this is something, mental health services is something that is needed across the board. And anyone who's even slightly inclined to do counseling, to do psychology, I want to tell you that we need you. And please don't hesitate to take online courses, to learn how to speak like not a scientist, but like a human, right? We all have, well, sometimes doctors, believe me, I know I know my kind, and we really get off the bowl, we get off the track. And what patients who get viremic need is understanding and kindness and patience and appreciation. So the critical issue is improving our service delivery, because really we have the best regimens that are available. And what we have to do also is engage communities, battle stigma at every possible area and place. And we must keep our patients alive, at least for the next 2 years, alive and suppressed, so that when these long-term injectables come, when we only need to have one injection once every 6 months or one pill every 6 months, we haven't accumulated so many resistance mutations that that medication won't work. So dual therapy is perfect for that, because few side effects, highly effective, cost-effective, and really, what more can I say? Except thank you very much. Nice to be here.